Well, here we are again with another episode on psychological disorders and continuing that topic. So let's get right into that. And uh, let's see, I've got to do a little bit of, okay, make sure that it shares the sound with you here. And then, okay, here we go.
We're going to begin here the second part of psychological disorders, beginning with mood disorders. Mood disorders involve emotional extremes or extended periods of time in a mood state that is undesirable. We will look at two principal forms of mood disorders: major depressive disorder and bipolar disorder. Major depressive disorder is sometimes called the common cold of psychological disorders, just like a lot of physicians see many patients coming in with colds. So psychologists and psychiatrists see a lot of people coming in with depression. Now, that said, the analogy doesn't hold up. It's very rare for someone to die from the common cold, although depression sometimes can be fatal. So in that sense, depression is considerably more serious. The World Health Organization indicates that depression is the leading cause of disability worldwide. Now, in fact, being temporarily depressed may be an adaptive thing. It may actually benefit us at times. For example, if we've lost our job, depression might get us to slow down, think about it, and consider how we might have had something to do with that, and maybe get us to consider some changes we might make in the future. That said, major depressive disorder, rather involving temporary sadness, involves a chronic state of depression for long periods of time. And whereas temporary sadness might be like gasping for air after a hard run, major depressive disorder is more like a chronic shortness of breath. Now, in order to be diagnosed with major depressive disorder, the person must have suffered from at least one major depressive episode. This is a period of time, 2 weeks or more, every day, most of the day, the person experiences either depressed mood or loss of interest in formerly enjoyable activities, or both. In children and adolescents, this also may manifest by irritability. And then, in addition to that, at least three of the following: feelings of worthlessness, thoughts of death and suicide, disturbances of sleep and appetite, either more or less than what is normal for that person, difficulty concentrating, lethargy, which is sluggishness, fatigue, loss of energy, or psychomotor disturbance, a slowing both physically as well as mentally, or agitation. In contrast, bipolar disorder is a situation where a person experiences both depressive episodes and also manic episodes, periods of mania. Now, in fact, we know what a depressive episode is and the symptoms of that. A manic episode involves a week or more where the person experiences extreme elation or euphoria. It's as if they're on a high. Or it can be also irritability as well. And during that week or more, the person is subject to impulsive actions, acting without thinking, shows hyperactivity, always on the go, And there may be a decreased need for sleep. They may sleep only a few hours a day, or maybe go for long periods of time without sleep. And their judgment may be poor. They may come up with ideas that are not realistic, that are, you might say, delusional, things that are not really they're capable of doing. And they may have an inflated sense of ability during this time. In fact, they may do things that endanger themselves and others due to this poor judgment. They might drive down pecan going 120 miles an hour thinking that they can handle that. They might have sex with anyone that they can and risk contracting sexually transmitted infections. Or they might charge up their credit cards to amounts that they never would be able to pay back. They might have unreasonable ideas of what they can accomplish. And during this time, if we try to intervene and we try to tell them slow down and that their judgment is not so good, sometimes they may get angry, might even become aggressive. Because of these type of manic symptoms, then the person may have to be hospitalized during a manic episode in order to protect them from themselves as well as those around them. Now, in fact, some great writers, poets, musical composers, in looking at it today, we would say suffered from bipolar disorder. During that manic phase, they may have been very creative and produce a lot during that time, but once in that depressed phase, find that they can't write a thing. In fact, those with bipolar disorder are also at higher risk for suicide. For example, of the writers that you see here, all of which would have been considered to have bipolar disorder. I know for sure that Hemingway committed suicide. I'm not sure about the others. Now, in considering depression a bit more, and we'll focus more on depression at this time, how do we explain the development of this? Well, first of all, we know that it coincides with changes in behavior and cognition, the way the person processes information. And thinking takes on a negative bias. The person sees the glass half empty, as it were, thinks of all the bad things that have happened. They also become passive, and because they no longer are active, they don't get the reinforcing sense of accomplishment. They lack motivation, so they don't feel like doing anything, and that contributes to depression. Deepening. When we look at the rates of depression worldwide, we'll notice that women are roughly twice as likely to experience depression as men. And there are a couple reasons it's suggested for this difference. One suggestion is that men and women simply handle troubles differently. And men, when having troubles, will tend to act it out by maybe getting drunk or getting in a fight or driving recklessly. Women, on the other hand, tend to keep their troubles in, repeatedly think about those troubles, or if they do reach out to others, they tend to, again, talk about their troubles and dwell on them rather than distracting themselves with other activities. So this may contribute. Others have suggested it may be also that women experience more stress and pressure, often having to fulfill more roles than men, having to, for example, hold down a job while also being a parent and keeping doing a lot of the household chores. We also can note that stressful events often precede the development of depression, suggests that stress is one of the things that contributes to the development of depression. And for that matter, depressive episodes sometimes self terminate. Not everyone goes to get treatment, and some people just tough it out, and eventually the depressive episode passes. This would suggest some changes, whether those might be in that person's environment, in their experience around them, or whether there might be changes in, say, brain metabolism or bodily processes that have caused the depression to come and then go. We should also note the rates of depression are increasing, especially in adolescents and teenagers. Teens today report depression at 3 times the rate of their grandparents. If we look at it, there may be a number of factors that have changed our modern environment, may be pushing people towards depression. If we look at how today differs from our grandparents' day, we'll notice that today adolescents experience a lot more stress, a lot more pressure. There are higher expectations, whereas in the old days, you might not be expected to go to college, get a degree, get a high paying job. Often people were happy to get whatever job was available. Um, there's more stress, more pressure. Also, we find that today, some of my students mentioned how the social media may also be leading towards depression in some people. Cyberbullying, for example, may contribute. Even people you don't know may be putting you down. That can be very depressing for adolescents who really dwell on peer pressure a lot. And then also, the expectations today have increased greatly. People expect to have a lot more than our grandparents did. They were usually happy if they could have food and a roof over their head. Today, we have to have all that, plus the right clothing and a certain kind of car, certain phone, and you name it. So that's another thing contributing, as well as relationships within families and in the community. Friendships tended to be more stable years ago. Today, people are more mobile, families are not as close. And so, all of these things also may be contributing to increased rates of depression. And some would even suggest that people today get less physical activity, less sunshine than our grandparents did. Even this may be contributing, as well as maybe what we eat today as opposed to what they ate in the past. So lots of things there that potentially may be contributing. Now, in studying the biological perspective of depression, we should note that genes seem to have a significant influence. Mood disorders often run in families. In fact, if we have one identical twin who becomes depressed, their identical twin has a 50% chance of being depressed as well, much less with fraternal twins that are more different genetically. They have even now determined that certain gene variants increase the vulnerability to depression significantly, doubling it and maybe even tripling it in some cases. Now, in the picture, you see the Amish, and they've done much of these studies with the Amish, and it's not because the Amish are more depressed. They're not. If anything, they may have less depression, but the Amish are traditionally have been a lot easier to keep track of, so we can study them from one generation to another. That said, with the shows now that we're seeing with them leaving the farm, it might not be so easy to study them anymore.
Over the past decades, evidence has mounted that in some cases, abnormalities of neurotransmitters such as serotonin, norepinephrine, dopamine, in terms of not the normal levels of these or abnormalities in the metabolism of these neurotransmitters, may be related to certain aspects of depression. Now, having said that, these abnormalities are not necessarily seen in all people that are depressed. In some cases, for example, with serotonin, in some people, they find that raising levels of serotonin relieves depression. In other people, lowering levels of depression seems to relieve it. So it seems to be a rather complicated and nuanced relationship between these things and depression, maybe not even always involved. Maybe sometimes these abnormalities also may be a result of being depressed rather than the cause. So quite complex. If you want a little more information, I've included some links in the learning modules where you can go deeper. If you're a psych major, if you're a human biology or getting into the medical field type major, you probably want to look at that and get a little bit better informed as well. But we'll leave it at that for now on this one. We also have learned that the amount of brain activity is also related to depressive or manic episodes. And here you see in the picture an individual who, when in a depressed state, shows rather low levels of brain activity. And then when in a manic state, you see a great deal more brain activity, the brain being extremely active. And then in the right, again, when the person became depressed again, you see again the lower levels of brain activity. So also overall brain metabolism can be involved in some cases.
The social cognitive perspective contributes to our understanding of depression. Cognitions, the way we process information, the way we think about things, also may lead to depression. And we'll look here at several types of cognitions that may contribute to depression. Self-defeating beliefs, negative explanatory styles, learned helplessness, and rumination. Now we know about learned helplessness already. The person, after numerous bad things happen, gives up, becomes passive, and once they're no longer active, they don't receive the reinforcement, the reward of accomplishment, and so they become more depressed. Rumination is overthinking one's problem, dwelling on them, continually regurgitating the problem mentally and chewing over that problem over and over again. Depressive explanatory style is when the person explains events in a negative fashion that lead to depression. Now, I like to use the 3 Ps in telling about the depressive explanatory style. Your textbook is using slightly different terminology. But let's say, for example, the person breaks up with a romantic partner. If they see their situation as being permanent, and as the textbook says, stable, it'll never change. They say, oh, I'll never get over this. I'll never find anyone else. They're more likely to get depressed. And if they see this as a problem that is pervasive, or as they say here, global, where they believe their entire life is ruined. Oh, my whole life's ruined. Or they say to themselves, without my partner, I can't do anything right now. And that's going to also contribute to getting depressed. If they see the problem as personal, or as they say here, internal, they look at it, oh, it was all my fault, or it's personal. It means there's something wrong with me. Again, that's going to contribute to getting depressed. Now, on the other side, a more optimistic, explanatory style may protect from depression in situations like this. If the person sees the problem as being temporary, yeah, it's tough, but I'll get over it. There's other people out there. And if they see it as being specific to only one area of their life, yeah, I miss that person, but I've got family and friends, so my entire life is not ruined at all. And if they see it as being external for themselves, yeah, just wasn't meant to be, that other person wasn't so great anyways, they're more likely to cope successfully with it. Now, the social cognitive approach also suggests that cognitive distortions may then also be linked to depression. And these are ways of thinking that are not entirely realistic. They're very common. We all probably do some of these. If a person becomes too wrapped up in these cognitive distortions, though, it can get them depressed. And we'll just take kind of a sampling of these. One of these would be all or none thinking. And everything is black and white. It's either good or bad. So if the person had a relationship that ended, they might say, it was a total failure. It was a complete waste of my time. It was all bad. Well, as the person wouldn't have stayed in that relationship for any time if it was all bad. In fact, there were some good things about it. Or another example of all or none thinking, if we don't get every question perfect on the test, then it's a total failure in our mind. That can get you depressed. Also, we have misfortune telling. And here, this is the tendency to think one disappointment is inevitably going to lead to another. So maybe we apply for a job somewhere and they turn us down. And so we conclude and forecast, oh, well, everybody else that I apply with, they're going to do the same thing. So what's the use? And I might as well give up now. And of course, we don't get the job, and then we feel even worse. Another would be negative focusing. And here we focus only on the negative aspects of our experience. We are given a job evaluation, and the employer praises us for many things and notes many good things we're doing. They also include one area for improvement. And all we see in the whole evaluation is, that one thing that I have to improve. We overlook all the good things that were said. And that'll get you depressed as well, not recognizing all of the good things that come along. And we also have what they call dismissing the positive. Sometimes they call this snatching defeat from the jaws of victory. So maybe we've done something significant, we've gotten an award or we've gotten a high grade on a test, someone compliments us and we just say, it was nothing. Well, no, that's not true. It wasn't nothing. It's a significant accomplishment, and we should allow ourselves to enjoy that rather than looking at it as being nothing. So, in belittling our accomplishments, we may get ourselves depressed. And then one of my favorites, jumping to conclusions. Here, the person draws conclusions that are not consistent with the facts at hand. Maybe someone says to them, I don't think I like you very much. And so the person concludes, everybody hates me. Well, that doesn't follow. Just one person said they didn't like you much. They didn't even say they hate you. Someone, I'm sure, must like them, right? So it's really not accurate, realistic. And, we kind of laugh at that. It seems silly, but can catch ourselves sometimes doing that probably. Another thing that gets people depressed is catastrophizing. And here what we do is we take a minor problem and we turn it in our mind into a giant disaster that in our mind is inevitable. We get a low grade on a quiz, for example, and then we think to ourselves, well, that means that I'm going to fail the course. If I fail the course, well, then I'm not going to get into the program that I need. I'm not going to get into the vocation that I'm aiming for. I'm going to be unemployed for life. I'm going to be living in a cardboard box. I might as well give up right now. And catastrophizing gets people depressed, and it also paralyzes them so that they can't deal effectively with minor problems. We also have emotion-based reasoning here, and the person feeling down in the dumps maybe decides, oh, well, if I feel this way, nothing good's ever going to happen today. We have should-isms. This is a big one. The person puts unrealistic demands on themselves that they should or must accomplish certain things or reach certain goals that are really not realistic. Maybe they say, oh, I should already be making $100,000. Or, oh, I should have already graduated from college. Well, in fact, that's impossible for that to happen at that very moment. And so putting oneself in that place is going to inevitably lead to disappointment. Or maybe we say, oh, I have to get an A in this course or else. In fact, again, if that's not realistic, then we're only setting ourselves up to be depressed when it doesn't happen. We're much better off to say, well, I would prefer that I'd already graduated, but I'm going to keep working toward it. I would like to be making more money now, but that'll have to wait till the time. Or I'll do the best I can in the course, and I'll shoot for the A, knowing that sometimes you don't always get what you had hoped for. And then we have name calling. Whenever something doesn't go right, we call ourselves names. We call ourselves lazy or stupid. And of course, what happens is when we repeatedly do this, eventually we start to believe what we're saying, and we actually begin to believe that we're lazy or stupid. And then, of course, comes more depression or mistaken responsibility. The person assumes that they're the cause of other people's problems. And so maybe one's friend breaks up with their partner, and one assumes that, oh, it's all my fault. It must have been something I said that came between them. Now, this is very common with children. When children's parents break up, often the child feels that it's their own fault. And they say, tell themselves, oh, if I had only been better, mom and dad wouldn't have separated. When in fact, they really had nothing to do with it. So here's a whole bunch of cognitive distortions. If one engages in this sort of thinking regularly, you can almost guarantee that they're going to feel depressed. Obviously, changing the way one thinks can be a significant help in climbing out of depression, which we'll get into in the chapter on therapy. Now, in fact, you may witness then a depressive cycle, according to social cognitive theorists, and stressful event occurs, and the person then explains this in a negative fashion. This then gets them to feeling depressed, in a depressed mood. As a result, there are changes in the way they think. They become more negative in their thinking, and their behavior changes. They get passive and give up, and this then leads to more stressful experience. For example, maybe a student, this all starts out with, they did badly on a test. They explain this in a negative fashion. It just means I'm stupid. It means that my whole academic career is ruined, and things are never going to change. And so they feel depressed. Now that they feel depressed, their thinking changes as well. Oh, it's no use to even try to finish the course. and they say, oh, I don't even feel like getting up out of bed to go to class. I don't think I'll go. And notice this is going to then lead to more stressful experiences. They actually then do fail the course and not able to continue. So what we have here is a downward spiral that feeds on itself. Obviously, we need to interrupt this pattern at one of the early stages before it gets out of hand to prevent people from getting depressed. So psychologists in explaining depression then would look to the biopsychosocial model, noting that biological influences such as a genetic predisposition to depression, changes in brain chemistry, or damage to the brain due to stress and other factors might contribute, as well as psychological influences, a negative explanatory style, learned helplessness, gender differences in how we deal with problems, and then social cultural influences may come into play. Traumatic or negative events the person has experienced, cultural expectations that they feel unable to comply with, or depression evoked responses. That's something I didn't mention. Depression evoked responses. So the person is depressed and they walk down the hallway staring at their shoes with a sad look on their face. And of course, nobody really greets them or gives them a smile. Even if they did, they wouldn't see it. And so the person concludes, see, nobody cares. It's really true, nobody cares, and they get even more depressed. That's the depression evoked response. So psychologists say you need to look at all these potential influences that can contribute to depression. Now, I think at this point, that's almost a half. So we'll go from there. Tune into part 3 when you have a chance. The chat, then the rest of the topic.